C's we'll be going over, and remember, this is a system that works on hormones that are secreted, and these hormones usually work in some type of autoregulatory function where they signal to one another to have that other organ to be stimulated. When that other organ is functioning and stimulated, then it sends back a signal telling the other system to stop stimulating and to shut down. So we have 8 glands. We'll be talking specifically about them. Again, they're hormones. Some are directly placed into the bloodstream, and they have a function that automatically causes a reaction. Others travel longer ways. Here they're showing you we have the pituitary is the master gland. It's up in the cranium, and we have the hypothalamus that's also in there. You have the thyroid gland in the front of the anterior portion of the neck area, as well as behind that in the posterior aspect, when those posterior wings of the thyroid is the parathyroid glands. You have the pancreas just behind the small intestine, the first section, and the stomach. You have the adrenal glands that sit on top of the kidney, and then we have our reproductive organs. Okay, the hypothalamus, the command center, it'll stimulate these releasing hormones, which will then trigger the pituitary to send out other hormones. The pituitary gland, after being stimulated or releasing hormones, then will release other hormones such as the growth hormone here, thyroid stimulating, which would affect the thyroid gland. The ACTH goes out to the adrenal gland. Then you have these follicle and growth stimulating hormones, luteinizing. They would go down to your the sex organs or the glands, those organs in the reproductive system. The pituitary gland has 2 lobes, an anterior and posterior, and in the posterior lobe, that's where we secrete oxytocin, which actually stimulates uterine contraction, and then antidiuretic hormone, or ADH, which causes the kidneys to hold back water, not to pee. The thyroid gland, it affects the regulatory metabolism, if you will. It's the carburetor system, and it's set at a certain idle. If this idle is set too high, the thyroid function is overworking, and then all of the normal metabolic processes are increased. You get tachycardia, you get higher temperature, you have faster glycolysis going on. And on the opposite side, if it's not revving and it's very slow down and tempered, then you have a metabolic process that is slow moving. In the back of that, the wings and the posterior side of that thyroid gland are the parathyroid hormones. Calcium is released from the bone, and these glands here, when secreted, sort of turn on and off that system of calcium regulation. Thymus, we see this in early development, that it builds up and helps with the immune system. The pancreas, we have both endocrine and exocrine. In this case, we're going to focus on the endocrine side, and we're looking at insulin, and we're looking at glucagon. And this would help us to mobilize sugar into the cells for ATP, or energy formation, and otherwise to help break down the sugar that storage is. Adrenal glands, they sit on top of the kidney. They do several functions. We know that it works on the sympathetic nervous system, but we're not going to focus on that this time. Within that adrenal gland, there are different zones, and the zones we're looking at are the steroid producing ones that help with stress regulation. They sort of temper that overall and give some protection to the body. as far as being able to handle um, stress and illness, if you will. And our reproductive organs, important during the reproductive cycle, and we'll talk about that when we get into LND, labor, delivery, and childbirth. We'll go more over these. So disorders of the pituitary. Again, the pituitary really is stimulated from these releasing hormones from the hypothalamus, and then it has an anterior and posterior portion, and when it malfunctions, it can be because of lack of the secretions of these chemicals. We're looking at the posterior pituitary and antidiuretic hormone, and what's happening here is that when diabetes insipidus occurs, there's no stop peeing chemical going out, and so this person is just having excessive amounts of urination, and with that it's passing a lot of water, and with water goes sodium, and some of that is a problem because now their blood pressure will be affected because the volume down. And when we talk about volume, we also talk about sodium retention, and if that's not happening, then we have this large problem going on. Here you see they're talking about now what to do as far as the replacement. We're gonna make sure that we are replacing that's water deficit, and they're gonna give them the replacement hormone replacement here, desmopressin, sort of like vasopressin or antidiuretic hormone, just to offset that malfunction of no ADH. The other thing about the pituitary, we did see the ACTH, adrenal corticotropin hormone. This helps with the development of the body muscles and changes in the characteristics during the gender differences. And if it's not stimulating ACTH, LFA, FSH, these other sex stimulating hormones, then we have issues with growth and development. The thyroid, when it overregulates again, remember it was the carburetor, it sets the site tempo of the ileine, or its metabolism rate. And so when the thyroid is overstimulated, we end up having this over rev, and you see the signs right here of what's happening as the body is over revved, overdrived, overheated. Some of the causes are on the opposite side here. What's causing it could be an insult to the thyroid. It could be overstimulation of the thyroid from the pituitary. It could be the thyroid itself that's going off. And what's interesting here, I want you to take a look at, with the tachycardia, atrial fibrillation is quite a normal phenomenon with a hyperthyroid patient. So what we do is try to control that over rev, and by controlling the over rev, some of these medications and treatment protocols we don't carry, but we'd like to stop the overregulation of that hormone being released by the thyroid. So we blunt that, and we try to blunt the symptoms of the tachycardia with medications like as beta blockers to slow it down. We'd also like to control the release of any more what we'd call iodine, so that the thyroid can't make this its T3 and T4 conversions. So basically, this is what you're looking at, and a high suspicion would be somebody that complains of palpitations, they has overheating, they got thinning, they got some hair loss, they feel very anxious, and we see them with some rapid atrial fibrillation. They might even have an enlarged thyroid gland. Again, this is just one differential of many other tachycardic patients, so hyperthyroidism. We would normally see this whole package. The opposite is the low revving of hypothyroidism, and in this case, the person has the opposite revving. Rather than having this heat tolerance, they have more of a cold tolerance. Sometimes they may be, I wouldn't say a loss of weight or a gain of weight, but we definitely have this fatigability as underactive, low metabolism. Yeah, it's just supportive care, monitor a patient, and they might tell you that, hey, I had an operation in which my thyroid was removed, and so I'm on medications to maintain my normal metabolic rate. And they might be taking something like a T3 or a T4, like Synthroid medication to maintain that. Those glands that sit in the posterior wings of the thyroid are the parathyroids, and when we have an overstimulation of the parathyroid, it secretes the parathyroid hormone, and it's going to start causing the bone to just break down, not to the point where we have osteoporosis or fragile bones osteomyelitis. It's just causing the increase of calcium within the bloodstream, so we can build up some stones, muscle weakness, fatigue. Hypoparathyroidism, that means that maybe they did a thyroid issue, and when they were removing some of the thyroid gland, because these sit in the posterior wings, the posterior side of the wings of the thyroid. When they remove the thyroid, they try to save some of the parathyroids, but it could be removed, and you could have the hypoparathyroidism. Then we have then we have a difference in calcium just not being released. The diabetic conditions, I'm pretty sure we're familiar, so we'll run quickly through this. When blood sugars, insulin is not produced, then we have an issue with sugar being utilized by the cell. When insulin is produced, it's able to allow the cells to utilize the sugar, and with oxygen, we create ATP. Muscles that are being active in exercise just kind of generally are able to use the sugar, but over abundance of insulin will cause a rapid drop in blood sugar. This usually happens in our type 1 diabetics where they're on insulin dependent and become varied presentations of mental status. They're wet, they're altered, blood sugar is low, tachycardic. The opposite side is where they have a very high blood sugar, and that may be because they are on oral hypoglycemics. It's supposed to help the pancreas to secrete insulin. In this case, there's not enough insulin, and the body's just not recognizing usable sugar stores, and so as a result, it's breaking down other areas or other sources to use as a fuel source. This is where our ketone bodies are generated, so it starts using fat and muscle as a new source of energy. Another type of hyperglycemia is hyperosmolar hyperglycemic non-ketotic coma, HHNC, or which used to basically their body is able to maintain a little bit of its own insulin production, but not enough to maintain that. So what happens here is that the body is less likely to break down alternative sources of energy stores, such as the fats and the muscles, but we just still have this overabundance of sugar that's developing, and it's not being utilized. So remember, with the diabetic patient that has hyperglycemia, we're going to end up with the 3 Ps: a lot of excessive urination, and a lot of thirst, and hunger. The treatment for both are somewhat similar. Because there is fluid loss, we want to tank them up and get fluid back on. That helps to dilute the sugar, and hopefully we can correct the sugar issue slowly, and eventually they may be on some type of sliding scale or scale of insulin and sugar water. So we're not just trying to deplete all the sugar stores that they're taking. We give them some fluid. We'll watch that levels, and then insulin is introduced as well as some type of D5W, so that there is sugar for that insulin to be used, and that the cells can function Gestational diabetes. This next slide is talking about a patient that has uh, is pregnant, and now the pancreas itself is being overworked as a result of the pregnancy, and we're showing signs that this person might be diabetic someday, or close to be a diabetic type 2 patient, and requiring some assistance medications that they would take to stimulate the insulin production. Here is showing you some of the issues around that. Pregnant patients 25 and older are just a little higher up. Definitely a familial history. Adrenal insufficiency. This one we're looking at it goes to the adrenal glands, you see, and the adrenal glands, again, they sit on top of the kidney. They're not the ones that actually secrete. They're not looking for the sympathetic ones, but we're looking for the adrenal that secrete the steroids, and some are anti-inflammatory mineral cortisol, and then the other ones are mineral corticoids. That's like aldosterone here. So what's happening now is that when we have this insufficiency, um, that aldosterone is being affected, and as a result, we need to add more, and that's what this is saying. Addisons, we really would like to add more, and you'll find that there's going to be some water loss, sodium loss. The person is very fatigued. There's not enough of the hormone being pushed around. And again, here you see, remember, we look at what aldosterone did. Aldosterone was to bring back, hold on to salt, and what's happening is that salt is being used and is being excreted out. As following the salt is also the water, and so we develop these other symptoms. Cushing's is the opposite. You have a lot more, and so what happens there, cortisol production is a lot higher. These chemicals also help us during stressful situations, like MICT class, where we're just studying all the time. When we have an overabundance, there's the development of this patient having a round face, and you should Google this, round face and buffalo hump, and they seem to have the hyperglycemia. So I know this is a quick nutshell. We will practice a little bit more. We'll go over it, and we'll try to give you signs and symptoms in the scenarios so that you can depict between these. But these are endocrine dysfunctions, and we don't necessarily see a lot of the Addisons and the Cushing's. What we do see is the hypo and hyperglycemia. We may see a hyperthyroid case very infrequently, but it presents itself as the palpitations. Keep practicing.